supposed to be one of the biggest causes of cancer. Is that very true?
Breast cancer is not this causes that kind of a disease. There are some things that we know that cause breast cancer, and one of the main things in that is obesity.
What we as women are doing in our daily life that could potentially lead to breast cancer in the future.
There is no culture of really getting out there and working out to make yourself healthy. The person who's exercising is going to do much better in health-wise.
Can you tell me scientifically how consuming alcohol can directly affect the chances of developing a breast cancer in your body?
Alcohol has a strong link with breast cancer. It's just one of those cancers that is not really linked to smoking. Even very little alcohol does increase your risk of breast cancer. It just works slower in the female system. Having said that, there are lots of things that cause breast cancer. It is very much affected by your hormones.
I want to talk about girls who get irregular periods and are going through the issue of PCOS and PCOD.
Women who have PCOS, they tend to come with other breast benign issues. Most of the benign breast diseases don't become cancer. So you see that change at a cellular level, which does put those cells at a higher risk of turning into cancer.
You think those women are at the higher chances of developing breast cancer? Welcome, Dr. Karishma, to our show. You're one of the first breast cancer specialists and a surgeon that we're having on the show. And it's such an important topic because, around 350 women nearly are diagnosed with breast cancer every day in India, which means that every 4 minutes a girl is diagnosed with breast cancer. And India is like the country with the highest number of deaths because of breast cancer. And that primarily is because of lack of awareness which we have in the country on this topic. So I'm very grateful to have you today to talk about this and many things related to breast cancer.
Thank you. Thank you so much, Radhika. It's a pleasure to be here. Of course, my day job is being a surgeon, but I also really enjoy talking about breast cancer and spreading this information because I think, yes, a lot of people can do a lot of good treatment, but till the patient comes to the hospital, you can't start it. So I think the most important, perhaps, part of treating breast cancer as a whole in India is spreading awareness about it and talking about it.
Indeed. What are some common foods that we're consuming in our daily lives that can cause a cancer like breast cancer?
Breast cancer is not this causes that kind of a disease, but there are risk factors that are known and of course many that are unknown. But there are some things that we know that cause breast cancer, and one of the main things in that is obesity, especially menopausal obesity. So weight that you gain after your period stop, that's very, very important because that increases the estrogen level in the blood. So having said that, of course anything that makes you put on weight is in a way responsible for breast cancer, but other than that also red meats, any packaged foods and anything in high fat. So I would tell you that having what is homegrown, what is original Indian food is probably better. So fresh fruits, vegetables, avoid red meats and have lean protein. So making that change in your life will not just protect you from breast cancer but a lot of other things as well.
Yeah, but people who consume red meat outside of India, what is it in their immunity system that they do not get any diseases even after having it almost every day?
I think they do also have a lot of these issues, and I think we know that a lot of the Western world is suffering from this obesity epidemic, and that is pretty prevalent and known, and a lot of them are now making changes by increasing their total movement in the day, adding exercise and things like that, and also improving what food they're consuming and becoming more mindful of that. Fortunately, in India, we've never been a very high fat kind of a diet. That's not culturally what we eat. So we have sort of been not gone into that obesity epidemic. But now with standards of living improving, this is going up. So it's not like over there you don't have any of these diseases. We know that the number of stroke and heart diseases and blood sugar and things spiking, that is seen more commonly in people who are obese. And you will see that similar number over there as you would see over here. Even when it comes to breast cancer, the incidence is much higher there. We just have larger numbers because our population is larger.
Right. But, that's about some of the foods that might cause any kind of cancer. But, there are so many utensils also that we're using in our house. And aluminium is supposed to be one of the biggest causes of cancer. Is that very true? Or like what kind of vessel should you cook your food into, which might lead to the toxic chemicals being poured into your food?
So it is actually really, there is not much basis to it. It's not very research or evidence based to say that cooking in aluminium utensil causes breast cancer. There was a lot of questions that comes from somewhere and then gets perpetuated even by media and with no really basis in science, which I think is not right. So even things like putting deodorants, people say that has aluminum that blocks your sweat glands in you. There is no basis to that. There is no research that tells you that putting deodorant causes breast cancer. But so many people believe it and so many people talk about it, and I don't think it's right. So just cook your food in whatever non-toxic, traditional, even steel. I think surgical steel is something we use for surgery. So it's one of the most inert things that you can use to cook your foods, and that is least likely to leach anything into your food. So not surgical steel, but stainless steel.
But, tell me something about what we as women are doing in our daily lives wrongly that could potentially lead to breast cancer in the future.
So I would say the one thing that we can change as a country, as a culture, is exercising. And I think it's catching on a little bit in tier 1 and metro cities, but it's still a long way off. So, when you live in a village and you are doing farming or doing some heavy manual labor, you get your exercise in. But everything between that and people who are very into their health, between that is where most of the nation, maybe 80% of the nation lies. And there is no culture of really getting out there and working out to make yourself healthy. Working out to get work done versus working out to make yourself healthy. There's two different things. So what are the couple of things that you can change? One is eating healthier. The second, or probably first, is exercising. So if you see two people, one who exercises, one who doesn't, they're both the same weight. The person who's exercising is going to do much better in health-wise, even if they weigh the same, even if their height is the same. Overall they might look similar, but someone who's exercising, they just do better. And the third thing is alcohol. So when I talk about like lifestyle changes that you could make, possibly these three are the ones that I would, because alcohol has very strong links with breast cancer, because people, and there's this misconception, people always say, oh yes, of course, like smoking will be related to breast cancer. And it's just one of those cancers that is not really linked to smoking, but alcohol very much. It increases, it also gets metabolized in the liver. It causes DNA damage. So it just works slower in the female system. So it's more harmful for women to drink than it is for men to drink, especially when it comes to breast cancer, I would say. So those three changes that you can do is limiting your alcohol intake, eating healthier, and exercising. Even if it is as little as 30 minutes a day for 5 days a week. So if you can do that much, it's not a lot at all. It's the doom scrolling that you're doing before going to bed, or, when you wake up in the morning and you're like, oh, who's messaged me? Just take that half an hour. Go for a walk. It doesn't have to be something which is high intensity. Just to walk, some stretches, Surya Namaskar. I mean, options, if you look for it, are plenty.
So can you tell me scientifically how consuming alcohol can directly affect the chances of developing a breast cancer in your body?
Right. So alcohol has a strong link with breast cancer, and there are a few mechanisms that we think and some that we know. that would possibly cause this link. One of which is DNA damage, but that is similar to in men and women. And the other thing is the way it is processed in the liver. It increases your estrogen levels also to some extent. Now the thing is that in women, as little as 3 drinks a week can increase your risk of breast cancer. So even something what you would call a light drinker, that any alcohol increases your risk, not less alcohol and more alcohol. I say limit alcohol, but what I mean is stop drinking alcohol, because even very little alcohol does increase your risk of breast cancer. So, occasional drinking, like on a wedding or on an occasion, is different from drinking every week. And it is still okay for women who may not be at a very high risk for breast cancer, but this is also the message that we try to give to breast cancer survivors. Because, drinking has become such a normal part of our social engagement, that you go out for dinner and drinks, or, you go to someone's house, you have a drink. So it's becoming, and it was not earlier, it wasn't that common. So if you look at our parents' generations, women were, if we go to our parents, look at our parents' generation, not many women were drinking, but this number is increasing. So I think we have to take a step back and think about how much alcohol we're consuming and try to limit it as far as we can. So this doesn't mean that you have to stop drinking, but just, move from a larger drink to a small drink, add more water, add more mixer. So I think those are the smaller changes that we can make to limit it, even if you can't let it go completely. I think everyone has to be mindful of how much they're consuming. Having said that, there are lots of things that cause breast cancer. Ideally, you should have your child, as early as 18 years, or your 20s, to avoid your risk. Never take any oral contraceptives. Don't take any hormonal therapy. Breastfeed your child for as long as 1 or 2 years if possible. Can you make all of these changes and continue to live a life that you'd be happy with? Probably not. So you have to know the risks. You need to know what are the chances you're taking. And I think that's all you can do, is take sort of educated decisions for your life.
Why do you say, bearing a child at 18 is much simpler? That's like a lot of people hearing this will be.
Because yes, there is data that tells you that having a child after your 30s increases your breast cancer risk if you compare it to someone who has had their child at an earlier age in their third decade of life, which is in their 20s. If you breastfeed for longer, if you have multiple children, multiple full-term deliveries, that reduces your risk. So I'll tell you what, it's dial it down to how many period cycles you have in your life. So if you have your periods early and they continue for longer, say maybe 55 or more, then you're more likely to get breast cancer, because the number of period cycles you have is sort of very directly linked to your risk of breast cancer. So when you're pregnant, when you're breastfeeding, your periods stop. Right? So anything that makes your periods stop, whether it is menopause, whether it's pregnancy or breastfeeding, that kind of lowers your breast cancer risk.
Okay, this is so interesting.
Milieu in your body. But the hormonal milieu in your body goes up and down with every period cycle. And the hormones don't just affect your ovaries, they also affect breast as a secondary sexual characteristic, which comes up during puberty. It is very much affected by your hormones. So every time you have a period or just before your period, your breasts change a little bit and then go back to their dormancy and open a little bit, because there is a very cellular level, there are some changes, because every period cycle, every menstrual cycle, the breast and your uterus, they kind of plan for a pregnancy. When that pregnancy doesn't occur and your lining is shed, all the hormones go back to this thing, and so the breast goes back into dormancy. Again, during ovulation, again, those changes occur again. So with that change and proliferation, there can be a little bit of DNA changes or mutations that can increase and cause tumor or cancer. So when you have a very stable sort of a hormone, which might happen when you're not ovulating, which is what happens during pregnancy and lactation, that is the time when your breast is kind of very standard. There are no changes, it's just dormant.
But one cannot be pregnant for too many times to avoid breast cancer.
Exactly. You can't live your life
Yeah.
based on one thing, that is breast cancer. So we say that oral contraceptive pills, they increase your risk of breast cancer, but they also reduce the risk of certain cancers of the gynecological origin. So what do, right? So you live your life as best as you can, knowing all of this, but also still living your life. I had my first child after I was 30, but I was studying before that.
Yeah.
It didn't make sense for me to have a baby
Huh.
before. So we have this information. You know the AQI is bad. Will you not step out at all? You will, right? You might wear a mask, but you're still going out.
Yeah.
So you live life with the information that you have as best as you can. You can't control everything.
Yeah, that's true.
But there are small changes that you can make. Let's start from that. Exercise, eat your food right. Let's start with that.
Yeah. So since we were speaking about, periods, I want to talk about girls who get irregular periods and are going through the issue of PCOS and PCOD. Do you think those women are at the higher chances of developing breast cancer because of the hormonal imbalance in their body?
So there is no data per se to clearly suggest that now. But what we do notice is that women who have PCOS, they tend to come with other breast benign issues. For example, breast pain, some cysts in the breast. We see that more commonly in women who have PCOS and things like that.
But can that cyst be developed into a tumor?
No. So most of the benign breast diseases don't become cancer. So when cancer is there, cancer grows from cancer, or you will see a certain kind of change, which is known as proliferation or atypia. So you see that change at a cellular level, which does put those cells at a higher risk of turning into cancer. But something like cysts or fibroadenoma, fibroadenosis, these are not things that can convert to cancer.
But for example, if somebody has a lump on their breast, how do you identify whether it's a cyst or a tumor?
Right. So one thing is that a cyst and a tumor. A cyst basically means a lump or a lesion which is filled with liquid inside. So it's like a water-filled balloon. Okay. And a tumor is always abnormal, but it can be benign or malignant. So it can be cancerous or non-cancerous. So you can have a benign tumor and you can have a malignant or a cancerous tumor as well. And cysts can also be cancerous and non-cancerous. So let's look at it as any lump in the body, in the breast, can be cancer and can be non-cancer. How do we know what it is? So there are a few things we know is that generally cancer is something that we see in older women. So if someone who is 15 who comes to me with a lump, it's very unlikely that she has cancer because they're probably in the hundreds, the number of people who've had cancer at less than 20 or not even the hundreds. So it's very unlikely. But as you grow older, that risk increases. So if someone who's 70 and she comes to me with a lump, my first diagnosis, the first thing I'll think of is cancer. But if someone who's 20 and comes to me with a lump, the first thing I'll think of is it's probably benign. But you can't just based on age decide that. So what you do next is imaging. So imaging for a younger patient would be an ultrasound or a sonography, and for an older patient, and by older I mean 35 and above, would be a mammogram followed by an ultrasound. And on that you see. So often enough you are able to, based on that, take a decision whether you need to test this further. So it will tell you what the margins look like, whether it looks the same throughout, it's homogeneous, is the blood supply increased to it. So those are some of the things which we look at when we're looking at something which is cancerous. Something that's cancerous will have an increased blood supply, will have sharper margins or more lobulated margins, and that's what we're looking for. And if based on this, it can tell you they're sure it's benign or very little chance. So maybe 98% sure that it's not cancer, maybe 2% chance. Those are the things that we can observe. But anything with even a slightly higher degree of suspicion, we would do a biopsy for. But yeah, I mean, it's different for
Yeah.
everybody. But this is what is known as triple assessment, is taking a good history, examining the patient, even when we feel the lump, if it's soft, if it's moving well in the breast, versus is it hard, does it feel irregular, is there some changes in the skin? So often enough, when we examine somebody, we can come to a good guess whether it's going to be cancer or not, and then doing an imaging and a biopsy. So these three things together is known as triple assessment, and it has almost 100% accuracy for detecting cancer. So that's the gold standard for diagnosis. Yeah.
You mentioned that it's more prominent in older women and lesser in the younger ones.
Yeah.
What makes you say that, age is related to breast cancer? The older ones get it more frequently.
Right.
And in the fewer cases of younger women who get it, what is it in their hormonal system that makes them get that at such a young age, which is so not so common?
So, okay. So, in our body, we have DNA. Obviously, it tells they tell our proteins how to behave, what to make, what to not make. And all the time in our body, we have some DNA mutation, which is some DNA goes a little bit crazy, and there's some other cells that remove that bit and add the correct DNA or things like that. So these are known as sort of DNA mutations. When there is something wrong with the DNA, it starts sending the wrong message to the protein, and the protein starts making something which it's not supposed to make, which could be how a cancer develops. As you go through life, there's DNA damage, repair. Sometimes at some point, it's just the number of years and the permutation and the combination of that and the ratio of the number of times it's happened, there's going to be that one DNA that's going to escape this repair, or there can be some change. In younger women, when we see breast cancers, so it's just something that's happened, like the DNA damages there, some cells that have got, that are cancerous, that are growing. It can happen sporadically. There's no reason for it. But very often in younger women, we find that they have a germline DNA mutation, which means that if you've heard of BRCA1 and BRCA2, there are some there's some DNA that in every cell is damaged for that patient. So because of that damage, and it's there are very different types of DNA. So what I'm talking about, BRCA1 and BRCA2, they are tumor suppressor genes. It is their job, so when there is a problem with the DNA, to go and fix it. So when they don't have, or if there's a problem with that tumor suppressor, then they can develop a cancer. So in younger women, very often we do see it because of any DNA mutation. With older women, it's just a matter of luck. And also when your periods stop, when you're in that perimenopausal range, the breasts go on to go a huge change. So all of the breast that was active is suddenly going into its dormant stage. It is involuting. So from going into, from being like ducts and lobules, they're just kind of becoming fat. And they're not going to be working anymore. So sometimes in this stage, we often notice that all the DNA changes that are there might grow, your cell damages, which is there, which might become more prominent, and you may see cancers come up in this age range especially.
And from those women at the older age, why do some people get it and some don't?
There are some risk factors. As I said, if you're nulli gravida, which means you've never had children, you are at a higher risk of developing breast cancer. It used to be called the nun's disease because it was seen very commonly in nuns who were celibate, who didn't have children, who didn't breastfeed because of their hormones. And but it's not that we see women with 5 children and 7 children who still get breast cancer. So there is no vaccine for it. There is no way to immunize yourself against it. When we see breast cancer in younger females, we see a slightly less, to a higher extent of non-hormone dependent cancers in them, which is known as triple negative breast cancers. We see it more often in younger women, whereas in older women, we see that hormone dependent sort of cancer in them, less aggressive usually, more indolent. In younger women, we do see a little bit of a more aggressive disease, especially when it's triple negative. But having said that, you can't club even triple negatives, even though we do we say there are subtypes of breast cancer. This is hormone dependent. This is, triple negative, not hormone dependent. Then this is targeted therapy works for this one. But even within those groups, it's so heterogeneous that you cannot say that I will give you this medicine and I know exactly how this will turn out to be. So whenever we give any treatment for breast cancer, we may treat a group of patients in a similar way. So if we have 100 patients who are 65 years of age, they have a 2 centimeter tumor node negative that are hormone positive, we will probably give them all a very similar treatment. But do they all have the exact same response? Do they all have the exact same disease-free interval or an overall survival? They do not. Because every cancer is a little bit different in itself, which is why there is so much conversation about personalized medicine, and there's a lot of research that goes into it.
What is the node negative, hormone positive thing?
So when you look at somebody with breast cancer, you might have heard of grade, stage, and things like that. So stage is tells you at what junction sort of this breast cancer is at. So when breast cancer is growing, is it a small tumor or a big tumor? Is the lymph node involved or not? So when breast cancer spreads, it spreads through 2 ways. One is through the blood and the other is through lymph. So when it spreads through the first place it spreads to usually is into the lymph nodes which are present in the armpit. Sometimes to the lymph nodes that are also present along the breastbone, but usually to the armpit. And when it spreads to that, it's usually stage 2. When there is more advanced disease, then it's stage 3. And the minute it spreads out of the locoregional areas, but stage 4 is what is metastatic disease. That is disease that has spread out of this area, which means that that how much ever you can treat locally, there is disease outside. So this patient will not be someone that you will ever call per se cancer free. But we also do something known as immunohistochemistry, which tells us what will this cancer respond to? What is the treatment that it is more likely to respond to? And in some cases, it also tells us what the nature of this disease will be. Is it fast growing? Is it slow growing? That kind of a thing. So when we have hormone dependent cancer, we check estrogen receptor, progesterone receptor, HER2, which is a targeted therapy. And now we've also started checking something known as Ki67, which is a marker of proliferation, which tells us how fast this cancer is proliferating or growing. In an older patient, we would give something that kind of blocks the production of estrogen in the peripheral fat, which is where estrogen is made when you're someone who's menopausal. Okay, so estrogen is made generally in the ovaries in someone who's ovulating, who's premenopausal, who's menstruating regularly. When your periods stop and you go into menopause, ovaries shut down. So where is your estrogen getting made now? In the peripheral fat, which is why when you are obese after menopause, you have a higher risk of developing breast cancer. So you can give that treatment for a longer term. You can't give unlimited chemotherapy because it comes with side effects. So you do surgery, you may give some chemo, you may give radiation, and then you put them on a hormone therapy. Now, hormone therapy is a tablet that you need to take every day, which sort of blocks the production of these hormones or blocks the receptors where they're going to go and attach themselves to. And because of this, the risk of that cancer coming back reduces. And this effect can be sustained for a long time because you can give hormone therapy for a longer time. So we give it for 5, 7 or even 10 years. And so this really reduces the risk of cancer. Now, there are others that are HER2 positive, which is the second thing we check. And that's a target. Now, we give this targeted therapy along with chemotherapy. So up to about 10, 15 years back, we didn't have these. And these patients would do really badly. But this switch was found. And now we give targeted therapy, and these patients, if they complete that targeted therapy treatment, they do really well. Now there's a third kind in which all of these switches are off, which is the triple negative. So in those patients, they are more aggressive and it's a little more difficult to treat them. But in the last, I think 3 or 4 years, now we have immunotherapy, which really works for these patients. So that's the new hope that is there. And we've started using immunotherapy along with chemotherapy before doing surgery, and we see very, very good response. Overall, I think there's a lot of changes and a lot of newer therapies which are personalizing treatment. 20 years back, we'd give the same CMF chemotherapy to all patients, but now we can change it according to the subtype of tumor that you have. And that helps to not just give better treatment, but also to minimize the side effects.
Is there any precaution that women can take to avoid breast cancer medically from an earlier age? Or are these medications only to be taken after you have detected the cancer?
So in patients that we talked about who have a very strong family history, or who have BRCA positive, or in whom we had those benign lesions which were high risk. So we talked about proliferation and atypia. So if you have a lump, you do a biopsy, it's not cancer, but they say there's proliferation with atypia. That means that you may be at a higher risk for developing breast cancer. In those patients, we can give similar tablets to what we would give to a breast cancer survivor, and this reduces the risk of ever developing breast cancer. This is known as chemoprevention. Doesn't mean we're giving you chemotherapy, it's just the name. In those patients, but is that for everybody? No, it's not for everybody. We would not recommend it for people who are not at a higher risk.
And how do you check whether they're at a higher risk of developing breast cancer or no? Are there any particular scans or devices that make you...
There are some questionnaires that you can actually kind of do. You can't do online. You can go to your doctor and they can help you out with it. And you can see what your risk is. A lot of it is based on family. So it puts it all together and gives you a score. And that score can probably tell you whether you're at a higher risk or not. There are other tests also. So if you have a family history of breast cancer, ovarian cancers, prostate cancers, then ideally the person who has had cancer should check themselves for germline mutations, which is usually a blood sample which is taken for genetic testing. If they don't have the mutation, then ideally you're kind of in the clear. You may be at a slightly high risk, but not at a very, very high risk. But if, say, your mother has breast cancer, she checks her DNA and she finds a BRCA1 mutation. That means the daughter, when she turns 18 years of age, should also check herself for that same mutation, understanding, of course, the implications, higher surveillance, and everything that comes with it. We always counsel our patients very extensively when we ask them to do these genetic tests. So those are the patients in whom we know that they have these kind of mutations, which puts them at a higher risk, at least 20% or more lifetime risk of developing breast cancer. Those are the patients in whom we give these strategies of chemoprevention. We even offer to do a bilateral mastectomy for a lot of these patients, and ovarian surgery, because ovary is the source of all the estrogen.
What is the first step that they should take today, and at what age group should they be to take those steps?
Okay. So if you're talking about family history, whatever age your family member or your mother has had, say, breast cancer at 40, you should ideally start checking yourself at least 5 or 10 years before that. Right? This doesn't always mean doing a mammography. This just means going to an oncologist, having a conversation, let them examine you, let them tell you what's appropriate for you. So ideally, in an ideal world, everyone who turns about 18 or 20 years of age should have a conversation with a mother, and a mother should teach her, how do you examine yourself? What does breast cancer look like? Because you don't have to fall sick to take care of your health, right? You can be healthy before you actually need to go to the hospital. So examining yourself, that's just really basic that everyone should be doing every month. Starting from the age of 30, you should be going to an oncologist or your gynecologist or your physician and having your breast examined by somebody who's trained to do so. And starting from the age of 40 or 45, you can discuss with your doctor, do you need a mammogram? And that can be something of a personal choice. Starting from the age of 40, if you have any of the risk factors, you can consider doing a mammogram. But also, it's very important to understand that mammogram is not foolproof. A lot of times you find random things on a mammogram, which causes a lot of anxiety.
Like what?
So there will be one small area of architectural distortion. Now we don't know what it is. Now we'll say, okay, come back in 6 months and we will do another mammogram to see if it has changed. and then it has not changed, but in those 6 months you're thinking about that, right? So it's causing a lot of anxiety. Or we when we do a screening mammogram, if we do just one sort of an image and we see something, we're like, we call you back, okay, now we need to do a few more images, okay, now we need to do a biopsy. We do the biopsy, it doesn't turn out to be anything. Or we do biopsy and it turns out to be something very, very low grade. And there are studies going on saying now that there are some sort of pre-malignant diseases, which is known as DCIS. You may have heard of it, stage 0 breast cancer, which is not breast cancer yet, but it may turn to breast cancer. But we don't know whether all of them will turn into breast cancer. So some of them may not. And there are cadaveric studies which they have examined cadavers and found that a lot of those women do have some DCIs which never actually turned into cancer, which was not the reason why they died. So if you do like an autopsy of a dead body, there may be some cancer cells in the breast. But did it matter to her? She didn't die because of cancer. So in some patients, there is a question of overdiagnosis and overtreatment, which is happening a lot. So now there are studies which are checking, can we just do a biopsy, maybe put this woman on a hormone receptor, a hormone tablet, and then observe it and see if there's a change. Does she really need surgery? Does she need any other treatment? Are we over-treating these individuals? So, so what I mean is that mammography is not foolproof, but it's more or less the only thing we have right now. I don't recommend anything else. There's a lot of things on the market with scanning and thermography. Ultrasound is not the same as mammography. If you choose to do an imaging, then it has to be a mammogram with an ultrasound.
How are some of these thermal machines trying to detect cancer through heat spots in your body? Like, how is the body temperature linked with you knowing whether you might have a cancer cell or not?
So it's just an area of higher activity. So it's that. So when you have an area which is, and cancer cells are like that, when you have an aggressive tumor, it's going to draw more blood supply, it's going to be actively multiplying, which is what the mechanism that we use when we give chemotherapy, which is why we have so many side effects, because when chemotherapy works, it works on all the fast dividing cells in the body, right? So breast cancer or any cancer cells are one of those. So the thermography machine kind of works on that principle, is that what is actively sort of dividing and producing heat per se. I like that. And
But the body could be having that heat because of any other infection.
Yes, very much so. So as I said, and I don't even have a problem with people who are overdiagnosed. At least they've reached the hospital and we'll examine them. But I have a problem with a low-grade cancer which will get missed. So that's the thing.
Now, you said in the Western world, most likely people develop this after their 60s, but in India it could be generally earlier. Why is that?
There is no one particular reason. One is, of course, that most of our population is young. So it's a game of numbers. So we have more number of people who are younger than their 50s. So we tend to have more numbers of women who are in their 40s getting breast cancer. The other thing is that we are a different race. So you're going to see a different type of cancer. You're going to see a different age of cancer. A lot of their cancers are screen detected, caught. So they diagnose a lot more cancers. They also diagnose a lot more pre-cancers, the DCIs, which get grouped off as cancers.
What's DCIS?
Is the stage 0, the pre-malignant. It could just be like an age-related small cancer, but they all get grouped as cancer. They all get grouped as cancer survivors and things like that.
Got it. And generally it's said that red wine is good for the heart. But when you said that alcohol intake can really lead to more chances of breast cancer, is wine intake also bad?
It's not a question of good and bad. Every alcohol works in a similar mechanism because of which it causes breast cancer. Is red wine good for you? So I think when something like wine, if there's any data that says that, it's good for you, it just gets talked about a lot more than when somebody comes and says, oh no, this is really bad for you, because nobody really wants to hear that. Yes, red wine has some antioxidants which kind of give it that little bit of a benefit. but that's about it. But the way it gets metabolized in the body, it still causes the same effect when it comes to breast cancer. It's just that a unit of wine is different from a unit of whiskey or vodka because of the volume of alcohol per weight. So you have to look at that, and based on that, understand what a unit of alcohol is.
So people should stop it fully. Even once a week is bad.
Yeah, so try to cap it. What you can do is, a lot of people have started doing that, is diluting their drinks a little bit more. Because I think the habit is to drink. You're not really chasing anything else, but it's just that you're eating and you're talking, you're drinking. So because of that, a lot of like unrequired alcohol intake happens, that you...
Also, you mentioned about the stages of different ways in which the cancer develops. And you said that the stage 4 is something which is very difficult to cure because it spreads into your body. Can you explain more as to what happens in the stage 4? Because in most of the cases, people get to know that they have a breast cancer only when it has reached stage 4. Before that, they don't even know whether it's there in their body or no.
With breast cancer, because it's a surface organ, we do see 90% of our patients before they reach stage 4. So only about 10% of our patients are metastatic when they come to us. And it's not, I wouldn't say it's particularly difficult to treat. Now, more than ever, we have more and more avenues to treat it. If you have met or like a deposit in the bone, yes, that bone becomes weak. It's difficult to put weight on it. You can give radiation to it. That's how we treat it. We can even do splinting, like sometimes we have patients with a fracture because of a cancer deposit in the bone. So you can even fix it. But it's not life-threatening, right? But when you have something which is involving the liver or extensive disease in the lung or in the brain, then this sort of disease needs chemotherapy. So you need a liver for your basic functioning of your body. You need your brain. Do you need every bone in your body? You don't particularly, right? So yeah. And then it also depends on how much. So you have one met in one part of the liver versus your entire liver is riddled with mets. Yeah, they're two different. So every patient is very different. We also now have a criteria called oligometastatic disease, which is, oligo means little. So there is a little bit of a spread. There is no particular definition for it. But we have started treating a lot of these patients with a curative intent, which means that we will treat their breasts, we'll take out their lymph nodes, we'll give them chemotherapy. We will also very often treat that other site as well. So if it's in the liver, we can put a coil and we can ablate it. We can sort of burn it using radio frequency or ultrasound or something like that.
You also spoke of, the development of personalized medicines for different patients, because everybody is going through different kind of breast cancer. So how is that development taking shape in India versus how it's been already done globally?
In India, we have all the technology. It's just the question of accessibility. Not everyone has access to everything because not everything is insurance-based. If you're in a country which has, say, the NHS, you can be the poorest person in the UK or the richest, and you will get the same exact treatment that you don't pay for, particularly at that time. The government's paying for it. You, of course, pay for it in terms of taxes and things like that, but you don't pay for it. So it's that. Everything is available, but it depends on, can you afford it? Or if you have some insurance, there's a cap to it. Does your insurance cover it? So unfortunately, it's things like that.
How much is the government giving in terms of the amount for the insurance?
In terms of amount, so we have a few. So of course, there is Ayushman Bharat, but not a lot of hospitals are on it. Then in Bombay, in Maharashtra, we also have Mahatma Phule Yojana, which is basically MPJ, which everyone who has a ration card of a certain kind can get free treatment for breast cancer. And it is between the hospital and this thing, I think they give around 20 plus 20. So you can't get treatment at a corporate or a private hospital, but in a government hospital, or in a charitable or a teaching hospital. That's where you can get. And even, I mean, it's a teaching hospital, so, and it's a charitable hospital, so anyway, the costing is not very high. It's about 22,000. There are some other schemes like CGHS, which is available at a lot of different places.
Okay. So for people who want to apply for the 20,000 surgeries, how can they?
That is the cost of the surgery in the
But
general side. Yeah.
if
You don't
somebody
have
has
to apply for it. That's the cost.
if somebody has an emergency, do they cater to it, or is it like full all the time?
Yes, very much so. So it's a teaching hospital. It is a charitable hospital. So of course the hospital absorbs a lot of the cost. And a lot of patients are operated under the Yojana. There is also funding from the hospital side. A lot of things are just operated for free. But see, sometimes if you need a cancer surgery, which also needs a reconstruction. So for breast, not so important, right? Because for breast, whether you're doing a cosmetic surgery or not is up to you. But something as functional, like if you're doing surgery for a mouth cancer and your jaw is coming out and you need a bone from this thing to put it there, those patients may have to pay a little bit more, because even post Yojana or whatever, that's not a 20,000 surgery. I'm talking to you about a breast cancer surgery. That's there are different grades of surgery. So it won't be 2 lakhs ever. Right? But it will also not be 20,000 for every patient. Whether it's DI or when I was working at Tata Hospital, Tata also gets a lot of funding. So even if patients under Yojana, but if they don't have a government scheme that helps them out, then even surgery there is about 10 or 12,000 rupees in the.
Okay. So how can anybody at home, especially anyone who's watching it right now, start understanding that, if they're doing okay or no, and would they require any medical help or assistance?
Right. So I think there are 3 main steps to it. And one is learn, look, and locate. And learning is, I think, very, very crucial, because you need to know what you're looking for, right? So to put it very simply so that it's easier to remember, what you're looking for is a lump, skin changes, or a nipple discharge. Now, a lump can be, hard, soft. It just feels like a ball under your skin. Okay. Skin changes has a lot of things. Now, there can be a redness on your skin or like an orange peel-like appearance. There can be a tethering or a small dimple on your skin, like the skin is getting pulled in somewhere. Or there can be a wound on your skin which is not healing. Now, nipple changes can be a nipple discharge or a scabbing on the nipple. Sometimes, other than that, you can also have a lump in your armpit or your neck that you feel without feeling anything on the breast. Now, this is the learning bit of it. And then is look, which is where you look at yourself in the mirror to see if there are any changes in your breast. Now, to do that, you strip yourself up to the waist, face the mirror, put your hands relaxed by the side, turn right, turn left, and observe your breast. Is the breast of a rounded contour? Or when you're turning, do you feel like any part is pulled inside or there's an extra swelling somewhere? Then you take your hands up and down and then bend forward. Now, when you're moving your hands up and down and bending forward, what you're looking for is movement. So moving your hands up, you're seeing, are your nipples moving? Is one breast getting restricted? Is one nipple moving more than the other one? Sometimes when you have these movements are actually moving the muscles under your breast. So something that is close to yours, maybe there's something not on the surface, so you don't see it or you don't feel it, but it could be very deep down, closer to your muscle, involving the muscle fibers, and you will see these changes there. You can also see some changes in the skin, like when you move your arm up and down, you might see like a little dimpling, which wasn't there when you were standing straight. You see it now. And moving forward again, you see how both the breasts falling the same way. Now, when you examine yourself, you lie down, preferably with a pillow under you. And then to examine your left breast, you put your left hand behind your head and with your right hand at the flat of these fingers. You don't do this. You don't poke your breast. With the flat of these fingers, you examine your breast. So if this is my breast, I'll go touch it, go around, touch it, go around, touch it, go around.
And what do people miss out on generally while doing the self-examination?
A lot of the times patient, one is forget to examine this bit. A lot of the time patients forget to check if there's any nipple discharge. They forget to press because that's a separate point. And a lot of times patients think that it's not important to look and do the whole turning hands up and down. They're like, oh, I'm going to examine myself anyway. But there are some tumors that are actually only diagnosed, when you look and you see those things, because it may be very, very deep, especially if you have a larger breast and you may not always be able to feel it. So all of these steps are thought out quite perfectly. So it's very important to do them all properly.
So for men who generally end up getting breast cancer, it's
Genetic family history. Not always, but very often. And even if they don't have any family history, men who get breast cancer, we always check them to see if they have a DNA mutation. They could be the first person to have the DNA mutation as well. So they could be that index patient. But what I do find is that the thought process कि मेरे को breast cancer हो ही नहीं सकता because breast नहीं है. That needs to be out. Because if you have a problem, even if your nipple say blood is coming out, why do you think that's not a problem? Why do you think that's like an infection that will
correct.
You need to show it. We had patients coming with 2 years history. We're just in shock. What were you doing for 2 years? But I mean, even women come with 2 year history. But
really,
yeah, there's just denial. There's complete denial. Like with this lady, she was in denial. She was like, no, it must be infection. Oh, it reduced when I took antibiotic. It's better now. So, she just went on. She was not willing to accept. Even when I saw her after 2 months and I said it has increased, I am almost completely sure it is cancer. She said, oh, no, you didn't see it. 1 month ago, it had reduced a little. So that's what, people do. It's a hard thing to even
accept,
of course. But if you ignore it, does it go away? No, it increases. So there's no...
That's really bad.
Yeah, or to go through that treatment. They may have seen somebody or things like that.
You spoke of obesity, right? And how it is linked to more chances of breast cancer. Do you think people who have heavier breasts, they are more prone to it because the accumulation of fat is much more for them?
So obesity works in 2 ways. One is that it increases estrogen production in the peripheral fat. The second is it puts your body into an inflammatory state. So any chronic inflammation tends to cause more DNA damage, mutations, and cancer, not just of the breast, of other types as well. So it doesn't particularly have to do with the size of the breast. Whether you have a larger breast or a smaller breast, the chance of your developing breast cancer is the same. It's not like someone, we have people with double A cups, almost flat women who also develop breast cancer. There is no relation in terms of size for developing breast cancer.
Okay, so the fat accumulation doesn't link to breast cancer?
Not in the breast. Bodily fat can contribute to breast
but not
cancer,
in the breast.
But not the breast size.
Got it. People say that if you don't wear a particular bra which fits the size of your breast, then it might also lead to certain changes.
So, if you wear a bra size which is not yours, which is too big or too small, what you will not get is support. So, because of that, just before your periods, you may feel a little heaviness, pain, etc. But does it increase your chances of breast cancer? No, it doesn't. No kind of bra, whether you wear a bra or you don't wear a bra, you wear a black bra, you wear an underwire bra, lacy, padded, doesn't make any difference to breast cancer risk. It can help to wear a more supportive bra if you have breast pain related to, the PMS and all of that. We advise a better bra support. And very often we have patients coming with breast pain because they're wearing a bra size which is not suitable for them. So that it helps in, but not with breast cancer risk.
Yeah. What are some of the new medicines that you have come across through your research or some global innovations in the treatment of breast cancer, which is revolutionary?
So I think one of the big things that came out was that HER2-targeted therapy.
What's that?
We talked about the different subtypes of breast cancer. And in targets, we had this HER2, which is trastuzumab. And after that, pertuzumab, and a lot of other targeted therapy that's come out. And in the last 5 years or so, I would say it's immunotherapy. Those are the 2 big things that have come out. In surgery, we're having more minimally invasive surgeries, which is robotic and endoscopic, which is a surgery, which is done through smaller cuts, and you can do a mastectomy through a 4-centimeter incision in the lateral part of your chest. But again, patient selection is very, very important. You can't do it in someone who has a lot of skin involvement. It's generally more reserved for patients who are doing it for prophylactic, which means your BRCA1 or 2 patients, which are high-risk patients, which don't necessarily have cancer, but are, we're doing it so that they don't get cancer. In those patients, it is more applicable. And there's so many new things that are coming out.
Which is the country that you really look up to in terms of innovation in cancer research and medicine?
A lot of Eastern Asia is actually, Southeast and Eastern Asia is doing a lot of innovation in terms of robotic and minimally invasive. So that's fun, and that's really coming up. But also in the last 1 or 2 decades, in the UK, is generally where a lot of breast cancer surgeons, or even in Europe, breast surgeons started doing a lot of plastic surgery, which is how oncoplastic surgery, which is when you do cancer surgery along with a bit of reconstruction, came in. If you go to America, there you still need a plastic surgeon to come in and do any reconstructive because of obviously medical, legal and things like that. But in a lot of UK, Europe, even in India, we are trained to do both. So a lot of people often question, like, aren't you bored like doing breast surgery every day? But it's so different every day because breasts are all different, diseases are different, you're doing reconstruction. So it's quite a bit of fun.
And lastly, I want to, touch upon a few of your client cases, since you deal in and out of, understanding patients in breast cancer.
Right.
So tell me one of the most unique cases that you've come across for breast cancer in India in your practice.
I've been in practice for 10 years.
Yeah. Okay.
So we talked about family history. Once we had a patient with breast cancer. She was having surgery for breast cancer in the opposite breast, and right after her or right next to her, we also had a sister. So she had a genetic mutation. We tested the sister. She came as positive too. So both of them decided to get admitted and have surgery on the same day. So we did breast surgery recon for one patient, bilateral, and then in the next theatre we did it for her sister who was having bilateral prophylactic surgery as well. So that was
Oh my
that was
God.
an interesting day.
And both of them got it because of their family genes.
Yeah.
That's crazy.
So that's why. So the person who had the cancer, we tested her. She came positive. So when somebody comes positive, we test their parent, sibling, and child, which is known as their first degree relative. So your parent, your sibling, your child. So they're 1 degree away from you. So those are the people we test again. So then the sister also came positive. And so then we spoke to both of them, and they chose to have. They were like, we will take a double room. We'll stay together. And literally, they were together and they were discharged at the same time because they had the exact same surgery and exact same healing, actually.
How long does it take in a breast cancer surgery?
Breast cancer surgery is so varied. Like, you can't say it takes 1 hour. So if you just do removal of the breast and close it, it takes about 1.5 hours. Or even a small, like you just remove the lump and the lymph nodes, that can even just be done in half an hour. But when you're doing a recon, depending on the kind of reconstruction you're doing, it changes. So if you're just doing a local flap, it will add an hour or 45 minutes to the surgery. But if you're taking tissue from elsewhere, joining the blood vessels under the microscope, that can take, almost like 5-6 hours. So 2 hours of your surgery, another 5 hours of that surgery. So it can even go up to 8 or 10 hours.
And what's the aftercare that a patient who's undergone breast cancer surgery, what is it that
Again, it
they need
depends
to
very
take?
much on the sort of surgery they've had. So if they've had a reconstruction, we would give them a compression supportive garment that they need to wear, almost up to 6 weeks to just make sure that all the sutures and everything heal well. And even longer, in fact, we would say 3 months, but definitely 6 weeks. And in patients who just had a simple surgery like a mastectomy or a breast conservation, they can wear their regular bra, they can go back to work, they can go back to their normal life almost the very next day on 1 or 2 days. They have a drain, which they need to take care of. We give them a bag that they put their drain in. But other than that,
What's drain?
drain is like a pipe that comes out of the surgical site. So any blood and the other fluids that the body releases into that negative space, that comes into that drain. So if you don't put it, then there's a swelling here. So we just let the body slowly get used to it, and the drain stays there for about a week, maximum up to 2 weeks, and then we take it out. Yep. So that, but it's not very heavy in the sense that you need bed rest. You can go back to your light work almost the next day. Just taking care of yourself, even some cooking and computer things like that.
Yeah. But I think after this episode, most of the people will become aware of the fact that if they have any breast cancer cases in their family, they need to get checked. Because half of the people might not know only that they are prone to it now, right, just because some of their family or ancestral would have had it.
So I think the message I would like to share is that it works both ways. One is that if you have breast cancer or family history of other cancers, that yes, it puts you at a slightly higher risk, but only 5 to 10% of cancers are actually from the hereditary route. 90 to 95% of cancers are sporadic. So it doesn't mean that if you've not had a cancer in your family that you can be completely relaxed and not do anything about it. It's imperative for everyone to be aware of breast cancer and also to go for screening. If you don't want to do a mammogram, that's fine, but at least come for a clinical breast examination. Examine yourself, know what breast cancer looks like. That's basic, and that's important.
Yeah. It is important, and I'm glad we spoke on this topic because the topics that we've covered, that's really immensely spoken about on the internet.
Yes.
It's all basic, normal information. So it was important to have a deeper understanding on it. And I'm glad that you gave us the time to do it.
Thank you so much.